RA, OA, you've had pain all last week, I think, maybe yesterday too. But so a lot of this, when we talk about these classes of medications you've had, you should be pretty confident with knowing, the contraindications for the class, the adverse effects, drug interactions. So a lot of this will just be looking at it with this disease process, this disease being either OA, RA, or gout, and then how that medication is used from that lens, right? In other words, is it for pain control? Is it for disease modification? Is it utilized at all as far as the anti-inflammatories? And so that's what will separate pretty much the lecture today is most of the classes, but then we just got to figure out how we use those classes and what line they are in your disease process. Basically, through the entire lecture, key things for you to look at is it for pain control or does it modify disease? In other words, is it decrease morbidity and mortality or is it just symptom relief? And a lot of the same drugs, NSAIDs, you're going to see showing up in your RA, your OA, and your gout. Corticosteroids, whether that be oral or intra-articular, show up in all three classes. And then you're going to have your unique ones as far as for gout and for RA. Kind of easy to pick them out because they're only used in those two different disease processes. So I'll try to point that out, but that'll be the key for the whole lecture. Is like this class, pain only, or disease modification, or only used in chronic gout versus acute gout. All right, you don't have to memorize every drug. As I mentioned in block 1, I like to put these slides in there, medications we discussed. This is more for when you're studying. When you get down to like slide 50 and you're like, what am I looking at again? You can go back up and reference this and say, okay, what's the class and basically what's the name of the drug? More of an outline than anything. And just a little precursor to the whole lecture is that, if you see disease control, NSAIDs and steroids are never for disease control. Definitely not in RA or gout. So learning objectives, basically the big thing with the medications that we're going to use for these arthritic conditions are going to be keying in on the comorbidities. Right? It's patient had chronic kidney disease, that rules this medication out. GI bleeding history, especially with the NSAIDs, and then cardiovascular disease with a bunch of the class. So, pregnancy always going to show up anytime there's a caution or a contraindication. You can expect that boards are going to test if you use it in pregnancy. All right, let's start with a little pre-knowledge check. So, anybody? What's the topical NSAID that's used for hand and knee OA? Some of you probably used it before. Diclofenac, yeah. Voltaren. Good, good. Usually hand and knee, that's what those products are kind of FDA approved for. How about the second question there to the right? Topical NSAID, do NSAIDs control arthritic disease? I just told you the answer. NSAIDs are usually just pain. They do not control decreased morbidity, mortality. They do not slow progression in OA or RH. And colchicine, you can use it in gout. And anybody know how soon it needs to be on board for an acute gout attack? 36 hours, 3 days. Early, or acute, it's 36 hours, needs to be on board. Colchicine does not work. I mean, 3 hours, yeah, that's great, but 36 hours, its efficacy is so decreased, it's not worth putting on board. I mean, if you can get that script in hand within 3 hours, great, but 36 hours, don't even bother with the colchicine. It's not effective. We have one more slide of these. All right, role of DMARDs. DMARDs you'll see later in the lecture, disease-modifying anti-rheumatics. If you see that, you know it's RA, because it's in the name, right? So what is the role of these DMARDs in RA? Anyone know? I mentioned it earlier, right? This is where you're going to control the disease process, right? Not pain, not just analgesia, not just any kind of anti-inflammation. DMARDs actually slow the progression of rheumatoid arthritis. That's why they're like the backbone of RA, because you can actually prevent mortality, prevent morbidity, and you can slow disease progression with DMARDs. There's a few different classes of the DMARDs we'll talk about. So to the right, Tylenol, first line for OA.
True.
True? Who says true? Okay, it's false now. It used to be true. It used to be true. It did. But now all the latest studies are saying, okay, if you can't handle an NSAID, Tylenol, the Tylenol is only good for really, really mild OA. But basically they're saying the risks, which are huge with the liver toxicity, with Tylenol, that only if you can't handle NSAIDs, consider acetaminophen. But it's not first line unless they cannot handle NSAIDs. And then anybody know what the serum urate target for gout is? 6 milligrams per deciliter. 6. So if you have gout, we want to get that blood test down below 6 milligrams per deciliter. Sometimes we can say down to 5 if you got gouty tooth line present, and we'll talk about what that means. All right, so you're somewhat familiar already. Start with OA. So it's mechanical, degenerative, it's chronic, it gets worse over time, wear and tear. We're all pretty knowledgeable what osteoarthritis is, right? It's what the being service does to our bodies after years. Wear it down, grinding. Eventually it could lead to bone on bone, can cause osteophytes, which I think you already had in ortho, right? It's bone spurring from the remodeling of the bone from the increased pressure. There is no disease-modifying therapy. So if any question ever says, for osteoarthritis, this medication is disease-modifying, prevents morbidity, mortality, progression of the disease, the answer is always wrong, false. Nothing can prevent or reverse and or keep the progression. Only treat symptoms for OA. But rheumatoid, bullet below OA there, it's systemic. It's autoimmune. Right? This isn't just wear and tear. This is like destruction of the joint caused by an autoimmune process. And if you don't get DMARDs on board for rheumatoid, joint destruction and increased morbidity and mortality. So DMARDs for RA can slow the progression of the disease, thereby decreasing mortality. And on the slides, it shows you where the most common sites. Think weight bearing for OA, right? RA can actually be pretty much anywhere in the body. We see a lot. I know you've had it in ortho, and I think radiology. You've seen some of the lesions that RA can cause, but RA can hit any of your organs as well, like really severe RA. So osteoarthritis, primarily weight-bearing joints, knees, hips, spine. A lot of folks get them in the hands. So treatment goal, functional, as I mentioned. Decrease the pain, increase mobility. You're looking at just improving quality of life. There is nothing about immune suppression for OA because it does not decrease the progression of the disease or halt the progression of the disease. It's not inflammatory. I've seen students get confused on this before. OA doesn't get bad, and become RA. Completely different. So there is never an inflammatory underlying process for OA. It's always wear and tear. So just don't get those two things confused. So if you see a question that says morning stiffness lasts all day, think RA, not OA, right? OA is driven by cartilage degeneration until we get that bone-on-bone contact, like I was talking about. Osteophytes and pain. Osteophytes being those bone lipping and spurring at the joint, crossing the joint line a lot of the time. So only reduced symptoms for this disease. It's not reversible. The only thing that is reversible is once you get down to the point where you're having a total joint replacement, right? Hips, knees, we hear about those all the time. But that's once the joint is completely shot, and it's not that you're reversing the OA, you're just cutting it out and putting something, metal, plastic, porcelain in there to replace the joint. You're not reversing the process, you're just replacing it with a new part. So usually, we're going to start with lifestyle modifications, right? Because it's weight bearing, weight loss, we look at diet, we look at things that can be done like PT and exercise just to improve your flexibility, improve, obviously, weight reduction is going to take some of the pressure off the weight bearing joints. But this isn't testable, but like if you have like a 5 to 10% reduction in weight, that will significantly reduce OA pain, specifically knee pain. So just a small amount of reduction in weight can lead to big gains as far as decreased pressure on the weight-bearing joint. So we usually start OA, and we all know if we've ever been treated for any kind of osteoarthritic condition, it's normally get some physical therapy, get some heat, get some stretching, those kind of things, easing our activities of daily living, and then medications on board to control the pain. A lot of times, most of the times, NSAIDs. All right, so goals. Now this exam flow the goal-oriented treatment. Basically just relieving pain, stiffness, improving quality of life through treatment. And obviously educating the patient. Topical NSAIDs, first line for knee and hand, especially in your elderly population. Why? Because there's less systemic absorption of NSAIDs with topical applications. So you don't get as much cardiovascular and GI risks with topical. And actually the diclofenac gel is like the only FDA approved topical, and it's specifically hand and knee. There's a slide coming up where we're going to talk about the American College of Rheumatologists and what they recommend. I'm going to give you that information, but know that that's not kind of what the American College of Orthopedic Surgeons suggests. They say first line for hand, not topical, is oral, but just for this lecture and for what's going to be on your boards, hand topical is usually first line. Oral NSAIDs, they're effective, but we all know about the adverse effects, right? GI being a big one, kidney, another big one, and cardiovascular risk. Acetaminophen, as I mentioned, only an option when NSAIDs are contraindicated. Tramadol, let's talk about tramadol for a second. So you see it in red, right? The American College of Rheumatologists says, hey, there's conditional recommendation for tramadol. I can tell you the PANTS, the PANRI, all the PA societies, tramadol is a no-go, right? Because it's considered an opioid. It's a class 4. It is kind of unique in the receptors it's hit. So we're going to slide on tramadol. We'll talk about it. But for our purposes, don't start, unless it's the very last option, tramadol for osteoarthritis. Because we just said it's a chronic degenerative disease process. And now you're putting something on board from an opioid class, which has addiction issues, decreased CNS function, respiratory depression. So it was like 10, 15 years ago, it was super hot, right? Because it wasn't classified as an opioid. So all of our patients that didn't do well with NSAIDs couldn't take it. Tylenol wasn't enough. We give tramadol. It wasn't a controlled substance. They used to make Ultraset tramadol with acetaminophen. It was like the best thing since sliced bread. And then after like 3 or 4 years of prescribing it, we started seeing the addictive behavior, people, running out of meds early, doing early refills, start having some comorbidities when they're hospitalized with CNS depression and a lot of addiction issues. So tramadol, for our purposes and your board purposes, don't even go down that road. You're just opening up a can of worms. But just know American College of Rheumatology still says it has its use. But if I were you, I would just, once you're out there practicing and when you're on your rotations, talk to whoever your preceptor is and say, hey, what are your thoughts on tramadol? Because you're going to get a lot of opinions on it. The board is definitely moving away from it. So this is that 2019 American College of Rheumatologists and Arthritis Foundation Osteoarthritic Guidelines. I put them up here just to show you that there are guidelines. These are specialists, right? These aren't primary care PAs. These are folks that only work in this realm. This is what they do. So there are a couple of caveats, right? There's the loxetine down there being a conditional recommendation. So it's SSNRI, you probably have that already, right? So starts messing with serotonin, the same as tramadol. But the big difference is on the hand OA. They're saying that conditional is topical, but for our purposes and for our testing bodies and the PAEA, topicals are first line for hand, especially in elderly patients. So there are a couple of caveats there, but I'm not going to test you on this slide, but just so that you're aware of it. Most of it matches up. And a lot of times you're not going to hear like what works for OA. It's going to be what works for this patient with OA, and there'll be some contraindications there, right? So things that you have to think about. Tylenol, like I mentioned, used to be, oh yeah, Tylenol, less risk than NSAIDs because it doesn't get the gut too bad, doesn't have any cardiovascular disease ramifications. But the big one for Tylenol that you need to know, and you probably already know, is hepatotoxicity, right? Liver damage, liver inflammation. That's your big, and really the only one for Tylenol. There's no anti-inflammatory effect from Tylenol. It's simply pain. And as I said, well, pain and fever. OA doesn't only cause fever. But obviously, that's another use for Tylenol. It is first line for fever. But for OA, only if you can't take NSAIDs, and only for mild OA. Works centrally to provide that analgesia and decreased temperature. We don't really know exactly how Tylenol works. The verdict's still out. Somewhat on the nitric acid pathway is what's thought. There's a lot of different research out there, but at this point, it's still not a closed case. Basically, if you can't take an NSAID, think you can try some Tylenol. Normally, you can't take an NSAID if you have one of those risks that we mentioned: GI, cardiovascular, kidney. If you see something about liver disease and an alcoholic or lots of alcohol use and Tylenol, those things don't go together, right? So if you got a liver issue and you're drinking, then you add Tylenol on, you're getting some hepatotoxicity or liver failure. So if you see that combination, think, oh, we don't need Tylenol in this person with a liver problem caused by alcoholism. The big key is it's no longer first line in OA. All right, so NSAIDs, this is where it's all happening for OA. Right, first line. Our oral NSAIDs, we talked in our lectures, during the hematology lecture, and I know you got in other places, about the difference between COX-1 and COX-2. Basically, the NSAIDs will inhibit COX-1 or COX-2 or both, and reduces prostaglandin synthesis. So that's how you get your decreased pain, a little decreased fever, or decreased temperature, and your anti-inflammatory effects. It's important to know about the NSAIDs, they're not all created equal, right? Some of them work on different COX pathways, and some of them have different potency levels or risk for adverse effects. So you don't just start throwing on additional NSAIDs if your patient isn't responding to one NSAID. You don't just throw in the second NSAID. Well, they're not doing well on the, ibuprofen, so I think I'll throw on some Mobic. When you start stacking NSAIDs, you start stacking adverse effects, especially the GI tract. So you're not going to use NSAIDs, and you probably already had this in pain, like gastric issues like gastritis. Big one is the renal insufficiency. A lot of times that will be tested. Can you use an NSAID in a patient? They give you some creatine clearance, and it's down like in the 20s. So, bleeding disorders, you don't want to put NSAIDs on board. Aspirin is an NSAID. We talked about it. It irreversibly inhibits the COX-1 on the platelet, but we do not use it in OA. Not preferred for OA. Because you're increasing the bleeding risk and increased GI toxicity, and you don't get a lot of anti-inflammatory effects. So we're moving on to the topicals. As I said, first line for knee and hand. That's what we're gonna say for all the NSAIDs. First line, knee and hand. Very good for older adult populations with OA, as I mentioned, because of less systemic intake. You're not getting as much in your system when you're having the medication absorbed into your skin versus when you're putting it directly into the GI tract, which only makes sense. You have decreased GI effects if it's not being metabolized through the GI system. And we don't use it with folks that have cardiovascular disease or GI or renal risk, even though it's lower effects on the GI system and cardiovascular system, it still carries the same warning, right, as your oral NSAIDs. So lower risk of those things, but the black box is still there for cardiovascular and GI, even for the topicals, because there is some systemic absorption. Okay, and then those are the big two, the diclofenac there. There's some others out there. There's some compounded NSAIDs, but they're not FDA approved. You'll see them, I bring it up because you'll see them, that there's some compounded topicals where they combine some NSAIDs, but they're not FDA approved, they're off label, but you may see them out there. Usually it's going to be diclofenac with something else. With the topicals, like the diclofenac comes with a card. It's like 4 times a day dosing. So the patient's basically carrying around this tube of gel with them. So every 6 hours they're having to put some on. All right, intra-articular steroid, right? So a steroid shot into the joint. Yes, it can help. Short term, it helps. It decreases inflammation. It's a steroid, right? So it's going to decrease the inflammation, but using intra-articular steroids chronically will lead to joint destruction. So now we're speeding up the process of joint destruction that happens normally with OA through our treatment. So you normally will not see more than 3-4 times a year anyone getting a intra-articular steroid into the same joint. And you can have some systemic effects that come along with steroids, and we'll talk about some of those with the steroid dose packs, prednisone, methylprednisone. But pain relief from an intra-articular injection, 24 to 72 hours, it kind of kicks in, and it can last up to a couple of months. A lot of times, when your patients are coming back and they're saying, hey, I want another one, I want another one, you just have to keep track of when the last one was, postpone it so you don't start getting into that area where you're doing more harm than good. And patients love them, right? Because it's like, oh man, the next day I feel great, no problem. A couple of months that wears off, they're back, they want another one. And then it gets shorter and shorter, and they're wanting more and more. And meanwhile, that joint is getting more and more destructive. So, good, it has a place for acute relief, but there are limitations to how often you can use it. And it's normally going to be triamcinolone or methylprednisolone. Orthopods sometimes will use some other injections for their intra-articular. They all have their favorites, but those are two big players. If you're giving injections more than 3 to 4 times a year into the same joint, there's a problem, right? You should not be going over that, and that's at the end of the scale. So use them wisely. If you're having to do them, more than every 2 to 3 months, then it's really not working that well anyway. Not only are you destroying the joint, but some of the systemic effects from having those steroids absorbed into your systemic system out of the joint you put them in, and start leading to more problems as well. Right? These are not benign, right? As I mentioned, cartilage degradation can happen if you keep putting a steroid in there. And then the big one for any steroid is if you start cranking up your blood sugar. So that diabetic patient with an arthritic knee is getting 3 or 4 injections a year. Now we're starting to get systemic effects. It could be raising their blood sugars and causing their blood sugar control to kind of get out of whack. Local risks, you are sticking a needle into a bone. So infection, tendon rupture, according to which joint you're going in, skin atrophy, because that steroid can accumulate, under the skin, because something's going to be expelled from that joint after you put it directly in, and you can start getting some local reactions too. So there are some adverse effects to intra-articular steroids. Kind of a caveat clinically is that we don't see this happen as much as far as the joint destruction in our OA patients. It's pretty, if you start going over the recommended dosing or the recommended procedures, we don't see that same effect in RA patients. Kind of interesting, but they don't have as much joint degradation because we're going to talk as we get in RA that we can control pain and inflammation somewhat with intra-articular injections as well. Not as much joint destruction. More of a clinical thing. Not going to test you on that. Tramadol, like I said, conditionally recommended. That matters. Word conditionally means, think twice about it. Okay. Tramadol, it's a partial mu receptor agonist, and it also has some effects on serotonin and norepinephrine. It's an reuptake inhibitor. It's an oral medication used for moderate to severe pain. Like I said, the boards are now saying, don't use it in OA, because you have to be able to not take NSAIDs. You have to not be able to take Tylenol, or it's ineffective per the American College of Rheumatology. But for our purposes, don't use it because there's a slide coming up that says drugs not recommended for OA. Number 1, not recommended for OA or opioids. And tramadol can increase risk of serotonin syndrome. You probably had that ad nauseum during your pain lectures, right? But it's important. Serotonin syndrome is not good, and neither are seizures. And tramadol can lead to both, especially if you've got an SSRI on board, kind of compounding that risk. Key takeaway, it can help with pain, but all of the boards and all the recommendations and guidelines are moving away from tramadol for OA because it is considered an opioid, class 4. And there's your caveat in red. Okay, to avoid opioids. It's like you have one society saying, hey, conditional recommendation. You got these two societies saying no. And the NCCPA and the PANTS say no. That's what you'll need for osteoarthritis. Glucosamine and chondroitin, your patients are going to take them, in my opinion, if they say it's helping them, okay, good. But we are not saying that there's medical evidence that it actually helps. Limited evidence showing that we should recommend it because there's no real studies showing that it modifies the disease process. But if patients come in, make your own decision. If my patient comes in and says, I'm taking this supplement and it's perfect, I feel better, I feel great, keep on keeping on, because there's not really any adverse effects with it, but just don't tell your patient that you should take this, it'll modify your disease, it'll lubricate that joint up for you. Studies don't really show that. There's some that do, there's some that don't. So the systematic review of all this information says there's really limited benefit, but if patient gets an anecdotal relief from it, by all means. You'll be asked sometimes about hydroxychloroquine and vitamin D. We're not treating osteoarthritis with those medications. And DMARDs, disease-modifying anti-rheumatic, right? So we're not using them in osteo, we're using them in rheumatoid. Didn't ask that question personally. Like, well, these drugs work for arthritis, so I want to be one of these drugs. They advertise them, every 20 minutes on television. Yeah, rheumatic disease always, not OA. DMARDs have no place in OA. All right, so we're going to move into rheumatoid now. So we're shifting gears from chronic, degenerative, mechanical. It gets worse over time. We treat pain to, okay, this will destroy joints, and we can reverse it or slow that progression if we choose the right medications at the right time. Systemic autoimmune, not wear and tear. It's from systematic inflammatory polyarthritis. Symmetric inflammatory polyarthritis, multiple joints. If it's left untreated, the joint gets destroyed, and long-term disability with use of that joint. There's increased mortality if we don't stop the process. You're going to see a lot of patients early on when they start having problems. It's going to be hands, wrists, feet. So what does that all have in common? Small joints, right? So obviously, any kind of destructive process is going to take place faster on a smaller bone or smaller joint. So RA is not severe OA, as I mentioned. RA is primarily T-cell mediated with activation of macrophages and cytokine release. So there's a couple of big ones that I'm just going to point out as far as which cytokines, because we are going to speak about medications that specifically target those cytokines. So those are the ones you really be aware of, which are the TNF alpha and the IL-1. So tumor necrosis factor alpha and then the interleukin-1. The ones we have medications that can affect this disease process that are targeted for those cytokines. So what happens with those two cytokines is they're inflammatory mediators, so they'll drive synovial inflammation, pannus formation, so pannus, that inflammatory material that's in the joint, we've had it, and then eventually it'll lead to bone erosion or rat bite lesions, right? What you had in ortho. Okay. TNF alpha, major therapeutic target. We're going to talk about that when we get into the different categories of the DMARDs. RA can affect skin, lungs, hearts, eyes, blood vessels. So if you see a question and you've got anemia or nodules in joints, lung disease, specifically interstitial lung disease, and they're asking for the arthritic condition, it's not OA, right? It's RA. It's systemic. OA is a joint that gets destructed. Now, can you have OA in multiple joints in your body? Yes, 100% you can. However, when you start to get systemic changes, i.e. your lungs, and changes in certain joints, and those nodules that you probably already heard about that happen in some of your finger joints, and anemia, you're thinking it's a systemic disease process like rheumatoid. And we're going to dig a little more into those cytokine targets as we get into the different classes. If you get the extra-articular, meaning the changes on the lungs or other tissues, not just the joints, that just means the disease progression of RA is advanced. The more things it's affecting, the worse it is. All right, goals in RA. Contrast to OA. OA is life, ADL, less pain, less inflammation. You're controlling symptoms. RA, we want the disease to be put into remission. We want to stop the process. Completely different goals than modifying, your lifestyle so that you take extra weight off of weight-bearing joints, doing PT so you get increased flexibility and all those kind of things, but not reversing the disease process in no way. Controlling pain. In RA, we want to put this disease in remission. Using DMARDs, disease-modifying anti-rheumatic drugs. Pain control is secondary and supportive. It has a place, but it is not reversing or stopping the progression of RA. In RA, NSAIDs and steroids, same thing as OA, right? We're just treating symptoms. Steroids and NSAIDs are not controlling the disease process. That's only DMARDs. The key to RA treatment, you've got to get it on board aggressively and early. And we'll talk about as we get into some of the classifications, which ones are your backbone that you're going to go to quickly. But like I said, for RA, you want to go after it aggressively with the DMARDs. The longer you wait, the more joints get damaged, and the more systemic things become. There are still non-pharmacological measures, right? Just like with OA, there are, even though drugs are the mainstay to reverse the process, still oftentimes when our patients are having real bad acute flare-up, we're going to recommend some rest or at least some joint rest if it's just certain joints like the fingers and the hands. PT, OT still has its place, once again, for ADL, activities of daily living, and decreasing pain, decreasing function, not reversing disease process or halting it. Assistive devices sometimes have to be used if folks' joints become non-functional, whether that be ambulation or things like to grab and turn with, if your hand strength is gone because of severe arthritic changes in the hand. And weight reduction, always recommended, always helps, right? You can get RA in these weight-bearing joints, so just like OA, if you can lose some weight, that's going to be less pressure on the weight-bearing joints, which will take a little bit of the pain away, but it's not going to reverse the process. So rest during flares, PT, OT during flares, assistive devices, weight reduction. But that's all adjunct. DMARDs. What you want for this disease. So if you say, well, I'm just going to do, the lifestyle modifications and kind of wait and see how it happens, you just let that disease progress. Non-pharmacological alone is not sufficient to treat RA. So here's the major drug categories on the right, pharmacologically, what we're going to talk about. Once again, NSAIDs, corticosteroids, symptoms. No disease progression is altered. DMARDs, there's some classes, right? We got our conventional, our tried and true, our classic, and then we're going to have biologicals. We'll talk about the difference of those. And then we're going to have targeted synthetic, which is a kind of new class of DMARDs. They're all DMARDs, they just work in different pathways. Duloxetine is now FDA approved for chronic musculoskeletal pain. That's an SSNRI as well. Not going to help with disease modification. Duloxetine, great that it can help with musculoskeletal pain, but once again, not going to cause any slowing or progression or decrease of mobility and mortality for your RA patient. Pain, and you can get good pain relief in RA, right? With these adjunct, with steroids, or it's oral or intra-articular, and the NSAID's on board, but you're not controlling the disease. So even though the patient may be having less pain by these analgesic and anti-inflammatory additions, that does not mean the disease is continuing to erode the joints. Right? So here's the overall, same committee, right? American College of Rheumatology 2021, these are the latest. They drive most of the therapy, and specifically the PANTS, and what you'll see there. But the key here is, if it's moderate to severe, methotrexate. That's your classic. That is your conventional synthetic. So you'll see that highlighted in blue over to the right. Moderate or high, you go with methotrexate. If a patient can tolerate methotrexate, they have already, they're getting methotrexate. We may add some of the other classes on, and this is just an overview. We're going to kind of give you a little bit more specific criteria for when you add more, when you take away more. But the key here is, yeah, you can use hydroxychloroquine for some mild disease. You can start there, but most patients get to methotrexate, the gold standard, pretty quickly. Now, if your methotrexate gold standard fails, now we can start stacking, right? We can escalate and use a combination of DMARDs from different classes, those biologicals, which we'll talk about. Remember we talked about just a minute ago, the cytokines, that TNFA1 alpha. So that's a biologic. We can target that with methotrexate. And then we talked about those target-specific newer class of DMARDs, like your JAK inhibitors. So you can; those are listed there. We're going to tell you what they all are. But the key is you normally start with methotrexate unless there's some major contraindication, and then if their disease process isn't controlled or the pain isn't controlled, then we're going to start. And they continue to get furthering destruction of their joints, and we're going to start stacking the different DMARDs. Right? Like I said, stacking, step up, however you want to refer to it. We treat the target. If you're going to start with methotrexate, unless they have some of the contraindications we'll hit when we get specifically to that medication. And then you can add other CS DMARDs, those classics, right? The classic synthetic ones with that. There were a couple there, and we'll show them in the next slide. I think there's the hydroxychloroquine, and there's one more in that class. But you can, if they fail the methotrexate, you can add another from the CS DMARDs. You can then start looking at the TNF inhibitors, or the non-TNF biologics, or the targeted synthetics, JAK inhibitors. The choice is really going to depend on activity, comorbidities, and patient factors. Will you, as a primary care PA, be deciding what DMARD patients are going to be on? Probably not, right? Probably not. But you need to be aware for boards, and you need to be able to know what's going on with your rheumatic patient when they're coming to see you for something else. Because the rheumatologist is probably treating them, right? Okay. We're going to hit NSAIDs again, but I think we've hit most of the points here. They don't treat rheumatoid arthritis. They treat pain when you have rheumatoid. They can provide significant immediate pain and inflammation relief, but no long-term joint damage control. Anti-inflammatories, if you're taking them every day, right, after about 1 to 2 weeks, that's when you're going to start getting some of the anti-inflammatory effects. So you have to take them for a while, systematically, having them on board once or twice a day, low dose. After about 1 or 2 weeks, you're going to start getting the anti-inflammatory effects maximized. But obviously, the analgesia, the pain relief, comes pretty quickly, within hours of taking an NSAID. As I mentioned, NSAIDs are adjunctive in RA. Usually, we get the NSAIDs on board while we wait on the DMARD to start working. And we'll talk about what that therapeutic window is in the next slide. So Basically, you can give them the DMARD, get them on the NSAID. The NSAID's going to give them some pain relief. Within a week or so, they're going to start having some of the anti-inflammatory changes, but we're still waiting on that DMARD. We probably started at the same time to kick in with this effects. Same as OA, right? Because we're using it for a different disease process, as i.e. RA versus OA, contraindications the same. Kidney, gut, bleeding. Okay, we talked about corticosteroids in OA. Well, mainly, not oral, but mainly intra-articular for OA. But corticosteroids are commonly used in RA, both intra-articular injections for severe joint destruction and oral, right? PO, like a prednisone or methylprednisone dose pack. And there's some examples of them there. There's a few different brand names. They have like strange dosing, right? You get a big little foil packet. You start tomorrow and it says one before breakfast, one after lunch, one before dinner, one after dinner, one before bed. So usually you do high dose in the beginning, and then you start tapering them down to like one pill on the last day, according to which one you do. That's what I mean when you say dose pack. Those are your common actors for corticosteroids in your RA. Not recommended long term. We've talked about the systemic effects. We use them mainly to bridge, same as we were using the NSAIDs. We can use them the same way in RA. When we get on a DMARD and we're waiting on it to kick in, we can put them on a short term of oral steroid, or we can give an IM injection of some steroids, or intra-articular injection of some steroids, but it's still only bridging therapy. We can use burst, those dose packs, or oral prednisone as a burst when someone has an acute flare, just to kind of bring the inflammation down. Once again, we're controlling pain and inflammation, not reversing the disease process. There are some folks that will end up on a low-dose maintenance steroid. Very controversial. There's lots of side effects of taking a steroid every day, but that's for the rheumatologist to figure out, not us. We're probably never going to put a patient on a daily corticosteroid. I would. That's something specialists need to be doing and recommending because of the severe systemic side effects that can happen. And even then, they're not modifying the disease. They're just treating inflammation and pain. So basically, long-term corticosteroids is not a good plan. If you see on any board questions that, we're going to treat our severe RA patient with daily steroids, or we're going to do it for 3 months, it's not a good treatment plan. The risk does not outweigh the benefits of that choice. They will control the symptoms fast, and we call it like the steroid euphoria. Same thing with the intra-articular injection. You give somebody a steroid dose pack, and the next day they are like, you've taken years off their life. Oh my gosh, I feel so good that I can move my hands, my feet, my knees, wherever their problem is. Now all of a sudden it feels fantastic, right? But it's very short-lived, and guess what they want the next time they see you? Another one of those. So patient education is huge when you're giving steroids, because you'll not only in rheumatic diseases, but anything. You get patients with a severe infection of some sort, and you treat them with a dose pack. But the next time they get an infection, they want a dose pack because it rapidly reversed their symptoms and gave them that quick relief. We talked about the common ones on your slide there. Let's go ahead and take 10. Back to 14. We'll not finish up the last 15.
I get what you mean by that. I get what you mean. Like it does have like a taste. We're supposed to unload those, but it's mild, you know, so it's not like you just find I see you at bridge.
Help me out a little bit.
Very centerfold. Inside that that thing moves. Saw that. Oh my
But some of them are pretty
What? Oh. You guys want to do something? Pharm? Yeah. I feel like she's still trying to play. Like, these are 5%. I don't know. I need it.
It's because of that young rookie they got.
But I feel like he has something. I don't think it's oh no,
I haven't been keeping up with it, but I know he's had it since I just quite
boy. There's also took 50 shots. Got 40 points.
You notice our Jesus is just a cute now. Someone stole our Jesus.
What? Where? Right there. No, that's yours. I don't know how it came to my side. This man, you got stunk.
They already played his drawing at the top down. Not a
Zach will love it. I'll take that.
says, I hope God can forgive you. Who said God loves you?
Start doing that.
You're like, Lord God, home.
Yeah, you don't.
Like that. Let's give it a death.
I was sitting here thinking, that's a road. Now I see all that on More to learn.
Oh, you're a Puerto Rican. That's where I left off.
Yeah.
Not that I
In the Baptist.
Stop.
stayed.
No, there's 4 categories.
That's
Bad
no,
seed.
it's an exudate or
Puts in reds. No. Well, there's like evil that does it. This one, hey.
Yeah, 4 different classes.
lateral. You're still on this but I know my
Oh,
never
no.
asked me to stay. Because he knows me very well. I'll be crazy.
That works. I said that.
Oh.
Osteoarthritis.
Maybe one of the 3. Yeah, so it's lactate. Yeah, lactate.
Is there still some in there?
So it's one
No, no, no.
and the other one's and then the third one is lactate. It's greater than 2/3 of the normal body.
No way we're going out of the fast line.
And you have and that means it's here. It's just eating lunch here.
That is tomorrow
Alright, I've got 14, let's go.
of the week, yeah. And then we have Monday.
So, long-term and short-term, adverse effects from the steroids. I already mentioned to you one of the big ones, we give patients with diabetes and issues, put them on a steroid is your hyperglycemia. And I think you've had steroids in a bunch of different lectures, so just be aware with the common short-term versus long-term effects of using corticosteroids. All right, so DMARDs, as I said, mainstay of treatment. They can slow and halt disease progression. There's very few pharmacological classes of drugs where we say that about a chronic, severe disease. That if you use this medication, you can prevent it from getting worse. So DMARDs are huge for controlling your RA patients. Start within 3 months. Now, will they be beneficial after 3 months? Yes. They don't lose their efficacy. It's just better when you have the signs and symptoms presenting themselves and you make the diagnosis within 3 months and you deal with DMARD. We talked about the 3 groups: conventional, synthetic. So you'll see that abbreviated CS, or sometimes you'll see T. Traditional, they're all the same thing. Think methotrexate. Biologic, well, they're biologics, so they act on those cytokines. Mainly it's your TNF inhibitors, but you have some non-TNF inhibitors in that class that are also biologics. And then that third bucket is your targeted synthetic, which are JAK inhibitors, which are the newer class. And we'll talk very briefly on what enzyme pathway the JAK inhibitors target, which is the JAK pathway. Anchor drug, methotrexate, first line. Start early. Most important thing about RA that is going to be said today, really. NSAIDs and steroids make your RA patients feel better. DMARDs prevent damage. RA without a DMARD on board is wrong. If you have an RA patient and they're not on a DMARD, they are not being treated by accepted medical therapy. This is just for our visual learners, and you'll see there that's where the different DMARDs act. We're not going to get that deep on the test, and the boards don't. Just you need to know the classes, and you need to know where they act, but not the specifics of the enzymes, unless it's in the name. Like I would know that the JAK inhibitors act in the JAK pathway. That's kind of straightforward. So conventional synthetic or traditional, methotrexate, backbone. Hydroxychloroquine, we mentioned hydroxychloroquine, that you're going to use that for mild disease. Sulfasaline, and lefonamide. You'll be able to pick them out of the lineup. Definitely no methotrexate. You start with the American College of Rheumatology for newly diagnosed RA patients that are what they call DMARD naive. Means they haven't had a DMARD. One of these drugs. Mainly methotrexate. The hierarchy is important on this slide. Recommendations kind of become less as you go down that list. Methotrexate, most efficacy, number one, been around a long time. Not a lot of contraindications and adverse reactions. There's a few we'll talk about, but then hydroxychloroquine, that's going to be more mild disease, usually moving more toward methotrexate. And then sulfasalazine, lefonamide, you may see them sometimes more added on to methotrexate or hydroxychloroquine. They're usually not solo players. Mentioned methotrexate is the cornerstone. You need to know, if you know a drug in RA is methotrexate. It's effective, it's inexpensive, and it can be used as monotherapy. And it can be stacked with other classes of DMARDs if need be. We'll talk about those situations. The PANTS loves to ask about dosing of methotrexate. It is not daily, never daily. It's weekly. You don't need to know how many milligrams. It's on the slide if you want to become familiar, but the key here, it's a weekly injection or weekly medication. PO, not injection, PO or IV. So they're either getting an IV with methotrexate once a week or they're taking a pill once a week. Not daily. Its mechanism of action is listed there. It works in the folate metabolism. That's about as deep as I'm going to go. I would know that what it inhibits, the dihydrofolate reductase, interfering with folate metabolism. So overall, that's going to reduce purine synthesis and limit DA replication in rapid dividing cells. Why is that important? Because its action is also kind of where we start to see some of its adverse reaction, right? At the end of the day, it decreases lymphocyte proliferation. Decreases white blood cell lymphocyte specific proliferation. Low dose weekly and then titrate up. 3 to 6 weeks, you'll start to see benefits. That's why I'm going to put on some steroids and some NSAIDs to help with pain and anti-inflammatory control while we're waiting on our DMARD to kick in. Basically, the delayed onset is the reason why we use bridging medication. Folic acid supplementation, mandatory. Know that. On the DMARD, you need folic acid. Supplements are mandatory. They're going to help with the side effects of GI toxicity, bone marrow suppression, because I just told you that methotrexate, or the CS class of DMARDs, are going to inhibit lymphocyte proliferation. So the bone marrow suppression that's happening can be alleviated somewhat by getting folic acid on board. You can also add folinic acid, which is leucovorin, if folic acid isn't reducing the side effects as far as your GI toxicities, stomatitis, and your bone marrow suppression. And it's the antidote if there's toxicity. So I would know that. I would know leucovorin, that it can help with side effects if folic acid isn't enough, and it's also your rescue for toxicity from methotrexate. Like we mentioned in drug 1, if anything's bad enough to have a reversal agent, you should probably know the reversal agent. GI, most common with methotrexate. Nausea, vomiting, and mouth sores, stomatitis. More serious can be that bone marrow suppression, liver toxicity, pneumonitis. Because methotrexate targets those fast-growing cells, then those severe side effects kind of mechanistically should make sense to you. You're going to monitor. Know that you monitor liver, function tests, CBC, platelets. Why are we doing the CBC? Because we talked about decreasing lymphocyte activity. Monitor patients who have alcohol disease or liver disease. Monitor their AST and ALT more often. Initially, it's every 2 to 4 weeks for the first kind of 90 days, and then we're going to do like every 3 to 4 months. And this is a comorbidity that's driving us towards more frequent monitoring of the CBC and ALT and AST. The key drug interactions are NSAIDs, and then that class of antibiotics, SMX, TMP, methylprim, and probenecid. And we'll talk about probenecid a bit later. Because all the drugs reduce renal clearance, anything that's going to reduce renal clearance of methotrexate, and the methotrexate levels are going to go up, and you're going to get bone marrow suppression and GI side effects, and liver side effects. Women should avoid pregnancy for at least 1 menstrual cycle on methotrexate. Studies also show that men who are on methotrexate, if they're going to try to conceive with their partner, they should wait at least 3 months after stopping the medication. There's some studies out there that show genetic damage to spermatozoa with methotrexate. So the key is avoid at all costs in pregnancy. If your RA patient becomes pregnant and they're on methotrexate, stop immediately. Great. I mentioned to you the 2 other meds that are conventional, or CS, conventional synthetic, or the T, traditional. There they are. Hydroxychloroquine, mild. It is safe in pregnancy. Hydroxychloroquine is safe in pregnancy for mild disease. And then the other 2, just adverse effects are listed for you there. You've probably already been tested on the sulfasalazine causing the discoloration of urine to your sweat. If not this semester, I think last semester, right? Hydroxychloroquine, safety in pregnancy among the CS or traditional DMARDs. That's important. All right, biologics. We've already hit them pretty hard. They target specific immune pathways rather than broadly suppressing the immune system. All biologics, because they are biologics, increase infection risk. That's what you need to know about this class of DMARDs. Infection risk is elevated. Because they're target immune suppressors, and your infection risk is going to go up when you put anything on board that's targeting immune response. They block key inflammatory mediators, so neutralize cytokines that I mentioned, the TNF alpha or the interleukin 6, and basically they block receptors on immunity cells and prevent T cell co-stimulation. We're not going to get that deep into the weeds, just know they're biologics and they work on blocking inflammatory mediators, but I would know TNF alpha and interleukin 6 because some of the medications are specifically in those pathways. TNF alpha is a central driver of RA inflammation. Normally we're going to add a biologic to our methotrexate, our C or our other CS or T DMARD. Usually you won't see a biologic by itself. I mentioned the stacking. If a patient has any type of active infection, you do not want to put on a biologic. Do not give a biologic at the same time as a live vaccine. Once again, this all goes back to the mechanism, immune suppression. Most common is TNF alpha inhibitors. Neutralize TNF alpha, reducing inflammation, specifically in the synovial fluid and the synovium. You don't have to memorize every one of these names, just kind of know about the class. If methotrexate fails or has been not effective, we can add a biologic on, the TNF inhibitors. And there's your main players there. You've probably heard of them by brand name, more so than by generic name, like Humira and the Remicade, the Enbrel. But once again, we're talking generic in the class. On the test, if we put them there, we will have the brand, but you're always going to have the generic. We're not going to probably on boards see subtle differences between the players in this class. You're just going to know as a class what they do. Black box warning for biologics. I would know it. Cancer, lymphoma and cancer. We said it decreases proliferation of lymphocytes. Therefore, if it does too good of a job, then we got bone marrow suppression and we can lead to cancer. Doesn't mean we don't use it. It just means we monitor them closely. What I would know about hallmark for TNF inhibitors, right? Infection risk increases, cancer risk increases. And there's all your players in the chart, for those that are more visual with the chart, and all of your adverse drug reactions and monitoring are there. TB screening makes sense. Why, right? Hepatitis screening makes sense. Why? Because we've got our immune system depressed. So we want to make sure our patients don't get acute infection when we have their immune system not functioning also on all cylinders by the medication that we added on. Once again, I would know that we don't do live vaccines when someone's on. They don't get any live vaccines if they're on TNF alpha inhibitor or a biologic, any biologic. And you want to screen them for those infectious disease processes before you start. So if they have active TB, or they have hepatitis active, and then you put on a biologic, their TB and their hepatitis is going to get dramatically worse really quickly. Okay, like I said, in a step sequence, so we can't use our TNF inhibitor. They fail or it's contraindicated. Then we're going to move to the non-TNF biologics. Still in the biological bucket, but now we're talking non-TNF. And their pathways are either T cell activation, B cells, or interleukin-6, like I mentioned earlier. So the key thing to know is if you fail one TNF inhibitor, you don't fail all biologics, right? There's other biologics you can try, which work in different pathways and different cytokines and different enzymes. Specifically, TNF versus T cell activation versus B cells versus interleukin. Usually you're going to see the non-TNFA on board or added to methotrexate if the TNF alpha inhibitors are failed or contraindicated. And same as the other chart for your TNF alpha, there's your ADRs and specific comments to each drug. Once again, I wouldn't know minor differences from this chart. I would know, the class and kind of indications when you would use them and where they act as a class. If not in the TNF alpha enzyme pathway, because they're non-TNF alpha. And then just pay close attention to pregnancy in all of the classes, right? Your CS&Ts and your TNF alpha inhibitors and your non-TNF. Now we move on to the targeted synthetic DMARDs, and that's the JAK inhibitors. Inhibits Janus kinase enzymes. So what those are responsible for, they're intercellular enzymes, and as it says on your slide, they stimulate hematopoiesis and immune cell function. So it's a different signaling pathway, specifically the Janus kinase enzymes. They're oral. I mentioned the pathway that they block. Black box warning, malignancy, and we throw in a new curveball because now we're inhibiting hematopoiesis, right? So not just lymphocytes, but red blood cells. So thrombosis now becomes your major adverse effect, serious adverse effect. Malignancy still there, right? But thrombosis now moves up into our things to be aware of with JAK inhibitors or targeted synthetic DMARDs. And they do have your suffix to identify and playground with everyone else, right? INIDs, so you can kind of recognize those. Usually, this is like last line of the DMARDs. Infection and a clotting disorder or thrombotic disease, you don't want JAKs on board. JAKs can cause infection increase and thrombosis. All right, moving on to the final topic, gout. You've had gout, right? Even this semester. I know Major Davalos gave you a test on gout. Got nitty-gritty on diagnosis, what color the crystals are, and negative bifurcence, right? All that good stuff. We're just here to talk about the drugs of gout. So we're gonna assume if you passed this test or did well on the gout portion of this test that you understand it, and I'm just going to talk to you about treatment. From my understanding, when I consulted with him, all he really gets into are some classes of drugs used in gout. Then he talks more about making the diagnosis and how to make sure that it is gout, and then some of the targets for the blood work. But we'll just hit the drug classes because there's only a couple of new ones for gout. It's a spectrum, right, with acute flares, gout as a disease process. Hyperuricemia just means that you have more uric acid in your blood. Do you have to be treated for gout just because your uric acid levels are above a certain milligrams per deciliter? No, we don't treat the lab. We use the lab to help us if we need to use urate lowering therapy or not, i.e. keep from making the uric acid so that we don't have deposition of the crystals into the joints. But if someone's asymptomatic and they have a uric acid level over 6 milligrams per deciliter, you don't run out and start them on urate lowering therapy. You basically monitor if they have a flare. We're going to talk about what they do, and then if they continue to have flares more often or worsening disease process, we can talk about how we can decrease uric acid level through a couple of different drugs for urate lowering therapy. But the key is it's a spectrum of disease. A number does not tell us that we need to start treatment. Symptoms do. And then we monitor the number to get to our target. As we mentioned at the very first, what do you know, check on learning, the milligrams per deciliter goal. Once we've decided they have a gout flare and they need urate lowering therapy. Most of these patients are middle-aged men, but postmenopausal women then catch up pretty quickly as far as how the disease process is affecting certain demographics. Hyperuricemia does not always equal gout. That's the key. Hyperuricemia is a lab finding. Gout is a disease process, which includes hyperuricemia. Monosodium urate crystals deposition into a joint, usually that big toe, right? The first MTP, the diagram. The crystals of the monosodium urate get deposited in the joint, and it's really not the crystals, it's the inflammation process that your body begins due to the presence of those crystals. Because at a certain level of the uric, the monosodium crystals, monosodium urate crystals, once they get up to like 6.8 milligrams per deciliter, that's when they start to precipitate, and then the body has to put them somewhere. And usually that's a joint, and often the first MTP. So the crystals trigger inflammation, and people will say this is exquisite pain. You have a patient with this horrible, exquisite. They go to bed normal, they wake up either in the middle of the night or the next morning, and now they have this horrible joint pain. Happens very quickly. But gout pain and the inflammation is not mechanical from the damage from the crystals. It's the inflammatory response that makes it painful. Uric acid, just as a refresher, it's a waste product. Uric acid does nothing in the human body except for leaving. It does severe problems when the levels go up too high and it doesn't leave the body, and it starts to be deposited in the joints. But uric acid is inert in our system until it starts to get at a certain level and be deposited in the joint. Purine metabolism is how we get there. On the right-hand side of the screen, you will see that pathway. And then once that urate exceeds 6.8 milligrams per deciliter, crystals start to be thrown into the joints. And that's why your thresholds are below that number of 6.8. Normally 6 during treatment. Because at 6.8, that's when they precipitate out of the blood and start being deposited into the joints. Hyperuricemia, above 6.8. Many patients have elevated uric acid and never develop gout. So they can have hyperuricemia, but no gout. Do not treat isolated hyperuricemia. Risk factors: metabolic syndrome, obesity, chronic kidney disease, high purine diet, beer, wine, red meat. We've all heard the stories, right? There's a big list of them there. Remember back to block 1, which diuretics increase your risk for gout. There's two classes. Number 1, hydrochlorothiazide and thiazide-like. And number 2, loops. Know those. Again, red meat, seafood, alcohol, and fructose sweetened drinks. Beer is actually worse than wine for uric acid production. Alcohol is double whammy. Alcohol increases uric acid production and it decreases excretion. That's why you would usually hear, gout is a disease of excess. Right? A lot of times excess alcohol, red meat, seafood. But alcohol hits you twice. It increases your body's production of it and it decreases excretion. You get double hit from your double shot. All right, acute gout onset, rapid, often overnight. First MTB, that's podagra, doesn't have to be there. It's just one of the more common, most common. If you have a board question about nocturnal monoarthritis, it's normally gout. If you have an acute attack, red hot, swollen, single joint, most of the time uric acid is elevated. You can have normal uric acid, not uricemia, and have the signs and symptoms of gout. So it goes both ways of that equation. You can have no symptoms and hyperuricemia, but you can have gout signs and symptoms, and your uric acid level will actually be below 6.8. Up to 25% of patients can have a flare with normal urate on the lab test, normal uric acid. So normal acid with the signs and symptoms does not rule it out being gout. Maybe that's when you start looking, draw off the joint, look at it under a color scope and say, oh, look, it's yellow, pale, negative bifurgent. It is gout. But just know, both sides of the equation. Disease with normal uric acid and also no disease with an elevated hyperuricemia. Diagnosis is clinical plus or minus that synovial fluid, right? That lab, that draw out and examination for the bifurgence. TOFI, chronic urate deposition. There's some classic ones there. If that top left picture was in color, you would see that first MTP would be probably super red, very angry. But it can be showed in multiple places. There's in the dip. You also see it on the auricle there on the ear. Basically, you have these TOFI, that's chronic urate deposition into the tissue. Long-standing disease to get to here. So the presence of these TOFI will drive your treatment thresholds. If you have these, we're going to say, well, now 6 is not your target, 5 milligrams per deciliter now becomes your target. Because you've got so much of the urate in your system that's being deposited, we need to have another treatment goal to decrease these effects. The key there is that the TOFI is an indicator for ULT, urate lowering therapy, at a lower cutoff, right? Treat the acute flare and gout, and then we want to prevent future flares. You lower the serum urate chronically. I just mentioned the numbers, less than 6 for most, less than 5 if there's TOFI. Big things you need to understand are very straightforward about gout. There's acute flares, and then there's chronic. So you got to treat the acute flare, and then you got to give some prophylaxis if you go into urate lower therapy with the same drugs you give for the acute flare, and you don't start the ULT when you're in a acute flare. If you understand those 3 things, you got gout beat. And we'll talk about the different medications for each. So the acute flare, there's our friend NSAIDs, and then colchicine. That's pretty much, you only see it used in acute flares for gout. The key here is for acute gout anti-inflammation, not urate lowering therapy. You don't start trying to lower the urate levels through some medications that can do that, acting in that enzyme pathway of uric acid production. When you have an acute flare, you're just treating on the top left. NSAIDs, colchicines, and yes, glucocorticoids. And we talked about everything already as far as 2 out of the 3 of those options, and we'll hit what colchicine is here in just a second. acute gout, controlled inflammation, chronic gout, get the urate under control. And then we're going to talk about the different classes for chronic suppression for urate lowering therapy, xanthine oxidase inhibitors, uricosurics, and uricase agents. 3 kind of new drugs that you'll only see in gout, and you should be able to pick that out from the bottom 2 because it has uric as a prefix. And the top one, that's a drug class that's pretty specific to just chronic ULT therapy, and we'll talk about why that is, because if you paid attention to that earlier slide for uric acid production, well, xanthine oxidase is one of the enzymes that leads to production of the uric acid. So if we inhibit that, kind of like the ACE inhibitor does, an angiotensin conversion enzyme, same thing here. If we limit that xanthine oxidase reaction to an inhibitor, then you're not making uric acid. And this is just an overflow. You can go back and reference this after we get through each of them, but we're going to talk about it on each slide. This is more of a flow chart. But basically, exact same thing I just said. Mild, only affecting a couple of joints, all the way up to moderate. No preferred agents. You choose based on comorbidities, prior response, patient preference. But there was those 3 classes on the last slide that we talked about for the acute flare. Topical ice, not sufficient alone. You got to get some medications on board. But yes, some topical ice on that swollen red toe will probably help with the inflammation. There is no one size fits all for gout, either acute or chronic. Mild to moderate flare, right? Just a joint or maybe a couple. You can use monotherapy. And I mentioned the one size not fit all. If gout is severe, multiple joints, large joints, intense pain, a lot of times we use combination therapy, and you see it over to the right. Colchicine and an NSAID, colchicine and an oral corticosteroid. We talked about the adverse effects of the corticosteroids and NSAIDs, and also you could do intra-articular steroids and an oral agent. But do not use an NSAID and systemic steroid therapy. Don't use an NSAID and systemic oral glucocorticoids. GI, because of the GI toxicity risk, is exponentially higher. If you give NSAIDs and a systemic steroid, you're probably going to get a GI bleed. Timing matters. Try to start some treatment for the acute gout within 24 hours. Colchicine, I mentioned it at the very beginning of the lecture, only effective if started within 36 hours. After that, colchicine is no longer an option. Poor choice after 36 hours. I would know that. So we hit on it. First lines for acute gout, indomethacin, naproxen, Solindax. What are those NSAIDs? Maximum dose, and you keep them on it until they don't have symptoms anymore, and then you taper them down. We're just treating the acute flare with an NSAID. Classically, indomethacin and naproxen are the 2 you're going to see. You can use the COX-2, Celebrex, silicocin, if you have GI precautions with the NSAID, and it reduces but does not eliminate that GI risk because of its action on the COX-2 and not the COX-1. So colchicine, we said acute flare had to be on board within 36 hours. It inhibits neutrophil migration and activation. So it's not an NSAID, but we use it in acute gout because of that neutrophil inhibition. It does not lower uric acid. It decreases the inflammatory response, which just a few slides earlier I told you that inflammatory response is what causes the pain and inflammation. It's not those little crystals, it's our body's inflammatory response to those crystals. So colchicine is going to target those microtubules on the neutrophils and inhibit them, therefore decreasing that inflammatory response. very specific dosing. We usually don't go deep into dosing. This medication we will, right? 1.2 milligrams at flare onset, and then 0.6 milligrams an hour later. And then further down the slide, we'll talk about, just like if you're using the NSAID versus the colchicine, you keep it on board until those symptoms are gone. Colchicine dosing errors, huge on PANS. This is the one time you need to know that dosing. Colchicine, GI toxicity go hand in hand. Nausea, vomiting, diarrhea, why do they go hand in hand? Because it's like 80%. Assume that if you give the patient colchicine for acute gout flare, that they're going to have GI toxicity. You can get severe side effects, including myopathy, if more likely if someone's already on a statin to lower their cholesterol, right? Bone marrow suppression, but very rare. It's another interactor with the CYP3A4 and the P-glycoprotein inhibitors. I would know colchicine plus a statin, myopathy. Steroids, we talked about them, how we use them in OA. We can use them in acute flare, just like NSAIDs, orally, intra-articularly, IM in severe cases. Sometimes if you stop the steroid too soon, you can have a rebound gout flare. Only use the steroids first line if the NSAIDs can't be used and colchicine can't be used. Summarize, acute gout, treat it early. Look at the comorbidities and decide which one you're going to use. Do not start urate lowering therapy during acute flare. If someone's already on it, if they're already on a urate lowering therapy, those three I mentioned earlier, we're going to hit them next. If they're already on that urate lowering therapy, it's okay to keep them on. If this patient hasn't been on urate lowering therapy or has had a drug holiday for the urate lowering therapy, do not start it when you have an acute flare. Treat it with one of the three medicines we just mentioned, NSAID, colchicine, steroids, recommended in that order. Then once their pain is gone, you're going to keep them on some medications or maybe change it up a bit when you start urate lowering therapy or chronic uric acid lowering. But you're going to give them prophylaxis, the same drugs that you give for acute flare, because there is a tendency to rebound when you start ULT or urate lowering therapy. Key for gout is know the difference between acute flare treatment and chronic ULT, which we're getting into next. ULT, urate lowering therapy, chronic gout suppression, this is not an acute flare. We're not treating pain, we're treating disease. So ULT is to gout what DMARDs are to RA. Keep that in your mind, right? OA, we're going to treat, we're only going to use NSAIDs and acetaminophen, some other medications, intra-articular steroids, only treat pain, inflammation. Then we look at RA, we can use those same medications to treat pain and inflammation, but hey, in RA we have DMARDs, slow disease progression, stop the disease from progressing or even happening at all. Same thing in gout. We can use NSAIDs, colchicine, and steroids to control the pain of an acute flare. And then we have the ULTs, three different classes, the ULTs that we can now put on board to stop the progression and mortality and morbidity from gout with urate lowering therapy. Xanthine oxidase inhibitors, that's your go-to. Allopurinol's first line, and we'll talk about the other one, the other XOI, which is fluvoxastat, and it has a cardiovascular black box warning. Then there's uricosuric agents, mainly you're going to see probenecid, and then there's uricase and pegloticase. Pegloticase, last option of the ULTs. And once again, do not start it ULT, one of these medications, one from these three classes, during an acute flare. Now we're looking at keeping that serum urate below the crystallization threshold. We said crystallizations at 6.8, but we said we're going to try to be below 6 milligrams per deciliter unless you have tophi and then what is going to be your signal. 5 milligrams per deciliter. Not everyone with gout gets ULT. TOFI, they get them. 2 more attacks per year, you get a ULT. Chronic kidney disease, stage 2 or worse, you get a ULT. And prior uric acid kidney stones, you get a ULT. Your first gout attack does not mean you automatically get ULT. We're going to give you the pain and anti-inflammatories, NSAIDs, colchicine, or steroids, and then we're going to check your levels and decide if we need to put you on ULT. And if you're having more than twice a year and those other indications there, you'll get one of those classes of ULT. But asymptomatic hyperuricemia, don't start putting people on allopurinol. What do these medications do? They block your uric acid production in a couple of ways, right? So your options are either the allopurinol, the febuzostate, which is an alternative to allopurinol, and then we'll talk about caveats for that medication. Think about the class of these, just like we talked about the class of the DMARDs. Think about the class of the ULTs, and it'll help you keep track of what we're getting after in those 3 different classes. So, of the XOIs, you can look over to the right and see where they're active. Right, you have allopurinol and febuzostat. They inhibit the xanthine oxidase, so you don't make uric acid. Same kind of concept as the ACE inhibitors with angiotensin converting enzyme. But here, you're inhibiting xanthine oxidase, so now you are not converting the uric acid. You're not having it made. From xanthine to the uric acid step, you're inhibiting that enzyme, keeping it from happening. Early flares happen from gout when you start ULT, and we're going to talk about why you put people on prophylactic treatment to keep that from happening. So the allopurinol is first line. It's effective, inexpensive, familiar. The febuzostat, it works the same way, but it has higher cardiovascular risk. That's what you need to know about that medication for the XOIs. Allopurinol is your go-to. The other medication works, but it has more cardiovascular risk. Adverse effects in this XOI class: rash, GI, cytopenias. Huge one that you need to know. Allopurinol has its own hypersensitivity syndrome, which causes Stevens-Johnson syndrome, or it can cause TEN, so toxic epidermal necrosis. You need to know that. That is your major risk factor with allopurinol, is allopurinol hypersensitivity syndrome. Severe rash with allopurinol, stop. No more allopurinol. Okay, now we're talking about uricosuric acids. Basically, instead of limiting the making of it through the XOIs, using an enzyme to keep from making uric acid, now we're talking about increasing the excretion of it. We're working in a different pathway now. Now you have uric acid, but we're going to increase excretion of it. And your big player there is probenecid, and you're going to use it only if XOIs are contraindicated or they're not working. You have to have good kidney function for probenecid to work. You'll also see their off-label losartan and fenofibrate. Just be aware of it. If you go back and think about the ARBs, you can probably figure out the mechanism, how they do that through that weak acid excretion port. I'm not going to hit that again. We're just going to say, hey, off-label losartan and fenofibrate can be used. Think probenecid when you start talking about uricosurics. This one, the creatine clearance has to be above 50 to work. So once again, when you start ULT, gout flares can happen. Prophylaxis required. We'll talk about that. Probenecid has its own unique increased risk, and that is making uric acid kidney stones. If folks have had kidney stones and they get gout, don't put them on probenecid. It also reacts with any renally cleared drugs. But any history of kidney stones, avoid probenecid. And now is the urate oxidase. Basically, this is an enzyme in its own form, right? You see over on the right, uric acid is converted to allantoin through urate oxidase, and then you pee away the allantoin, excrete it away. And so when you put more of this medication on board, you're converting the uric acid more into that byproduct allantoin, which is then excreted. So 3 different mechanisms, all in this same highway for the ULTs. They're just working at different pit stops. Only use this medication in severe gout, refractory to anything else. Not first line, last line. Why? Because look at the drug up top. What do you notice is unique about it? IV. Anytime it's IV, we're not jumping on it as first line. Significant risk for infusion reactions, anaphylaxis, heart failure exacerbation, and G6PD contraindication. I didn't know that. Extreme disease to put this on board. Why? Because we just talked about the adverse effects, which I think some of those you'd rather have gout than heart failure. Prophylaxis is the last topic. Basically, when you start treatment for a ULT, so you have your acute flare, give you 3 things. Then we're going to check you. We got to get you below 6. Oh, you got TO5 below 5 milliliters/deciliter. I'm going to start you on a ULT, one of those 3 medications, stopping at those 3 pit stops. Well, any of those medications, as we said, can cause an acute flare. So when I'm putting the ULT on board, we do prophylaxis treatment. What do? We basically treat as if you're having an acute flare when we bring it on board. And it increases adherence, right? Because if you start someone on an XOI and they have a gout rebound, after you start it, do you think they're going to continue taking that medication? Probably not. It got worse when you gave them this, right? So we give them some prophylactic treatment to increase the patient and decrease the patient abandoning their therapy. If you don't start with prophylaxis when you start ULT, then you're going to have treatment failure. Why that happens? ULT causes the uric acid to come out of wherever it's at, right? So it will be shifted out of tissues, and as your level falls, it's being pulled out of those tissues. Then guess what? The inflammation cascade picks up. Options for prophylaxis, same ones that you treat with acute flare, but a little bit lower doses. Low dose colchicine, low dose NSAID. Don't forget your PPIs. I'm sure that's been gone over with you. And then oral steroids as the last resort. Start prophylaxis with or before ULT. The duration depends on severity. If you don't have tophi, then you can go ahead and continue 3 months after you get to go. If you have present the tophi, keep going with the prophylaxis for 6 months. If they continue to have disease activity, they stay on prophylaxis until they don't. That's the key. It's not arbitrary when you stop, right? And so check the urate every 2 to 5 weeks when you're titrating the prophylaxis. And then once you get them at target, you can monitor about every 6 months. If you don't achieve goals, 6 without TOFI, below 5 milligrams per deciliter with TOFI, then you're just going to escalate stepwise dosage or medications. Right? Same way that you treat the acute flare. So treat to target. Treat to target lab goal. And that is all I have for you today. Just like first block, the check on learnings and the memory jobs will be added this afternoon, probably late afternoon. So they'll be there for you just for this lecture, like the other ones. I'll drop it in below the lecture. You'll have 3 or 4 check on learnings with why they're right, why they're wrong, and then you'll have you already have the memory